Okay, good evening, everybody. Welcome to this another session of 51st Comprehensive Course on Echocardiography. I'm Dr. Rakesh Gupta from Jorop Institute of Echocardiography, the largest training program in India for last 25 years. Well, as you know, we have the legends and eminent faculties behind this program, including Dr. Col SK Parashar, Dr. Naveen Chinanda, Dr. SK Chopra, Dr. Samir Srivastav, and Dr. Hans Gupta, apart from myself, who are at the helm of affairs. The two organizers, one of them we have been dealing regularly is Mrs. Reena Dua, another is Dr. R.K. Narayan. This course is powered by legends in cardiology. Training sessions are by leading cardiologists. We have multiple accreditation as of today. We are recognized by Indian Academy of Echocardiography, International Society of Cardiovascular Sound, Alabama, Delhi Medical Council. We do take permissions from Northwest District of Delhi for doing hands-on training programs. We do run a one-year training programs with association with Parole University. And lately for 1 year, we have been doing NHS training program in association with BTA. We can boast of saying that we are the largest or the only institute in Delhi in India providing state-of-the-art hands-on training. It was first conceptualized in April 2000 to provide state-of-the-art world-class training to physicians and cardiologists. More than 5,000 people have already attended this program, and we have completed 25 years of this training program with this batch. And we plan to celebrate the Silver Jubilee on 17th August 2025. Well, this is what was, we began with April 2000, and this is where we are in April 25th, 2025, doing 51st Comprehensive Course on Echocardiography. Many things have been done at our place. Many of these doctors, they have risen to the level of director of non-invasive cardiology in major cardiovascular hospitals. Innovation at all times. Next program, we try to be better than before. And we have delegates from around the world. You can see the reverse journey is happening from USA, Australia, and Canada. We do conduct hands-on training program in Jorop Auditorium in Delhi. We have an in-house accommodation, especially for female delegates who can stay in the same complex for their safety purposes. Multiple courses which are available right in front of you. One of them is a comprehensive course on echocardiography, which we have been doing since April 2000. And this is a stepping stone for subsequent courses. This course started on 9th of April, and hands-on session is going to happen on 19th to 22nd of 2025. This is one delegate we recently had our place, Dr. Deepak Jeswani. Sound is little poor, but he was here for us with 2 weeks of our training programs for in-house training. Then we are going to have a third session today, that is on April 23rd. The topic is Basics of Doppler Echocardiography, and I would like to welcome you all for this particular session. And we have a very eminent person in the field of cardiology, none other than Col SK Parashar sir, who has been the past president of Cardiological Society of India and Indian Academy of Echo. He was a founder of this one of the largest body of echocardiographers in India. Almost 4,000 members are there. He's a Lifetime Achievement Award being bestowed upon him by President of India. He has been the author of IE textbook of Echo and presently works in Heart Center in Lajpat Nagar. With these few words, let me have the pleasure of welcoming Col Parashar sir for his talk on basics of Dopplers. Sir, it's all yours. You can share your slides.
The slides are well seen?
Yeah, sir, they are coming up, sir. Yes, sir, we can enlarge them.
Okay.
Little bit. Perfect, sir. Perfect. It's all yours.
So, as we mentioned on the first day, that the first 2 lectures are extremely important for you because they make the foundation of your full course. So, I'm sure you must have really revised the first lecture so that you can subsequently go on seeing the other lectures also. Because on one lecture is based the other lecture also. So we'll be discussing a very basics in Doppler. Normally, this talk should not take more than 30 minutes, but I think we'll take almost about 45 to 50 minutes because it's a very basic thing. And we'll try to tell you something which you would have read in your MBBS must be forgotten by now. So some of them will be very basic. So at any time you can interrupt in between. That is in my talk here. Anything not clear, you can interrupt at the same time. So let us make it interactive also. Because in the physical lectures, we go on interacting on the site, but here probably because we are almost on the online, so we'll just interact by your question and answer with a doubt or so. And I said, whatever images I show you scan plane, if you can't recollect, don't worry. We only tell you the principle behind that image. If you don't recollect what image I've shown, but at least the principle we can say. Now, why we have put in this picture is that this is Christian Johann Doppler, so that whenever you write a word Doppler in your textbook or your reports, always it should be capital D. Remember, because it's the name of the person who Austrian physicist who could live only for about 50 years or so, but created a sort of left a legacy behind it. So it is just to say that you always write with a capital D like you like write any name. Now you know what the main mantras of echocardiography is a good clinical assessment. We have several examples, but it will be too premature to put them on now. But they'll be much better understood as you proceed into the course. Both operator and patient should be comfortable so that you are a beginner. You can know whether you want to do from the right side, whether you do from the left side. That is your choice, but both of you should be comfortable. Most important thing is to attach an ECG tracing. No echo without an ECG tracing, but why? We'll tell you research because we see the heart rate and we always write the heart rate and the blood pressure in our report. Then you know when you see the ECG which is diastole, which is systole. So, for example, if you take here, now this was only this patient was sent for an echo down, but when you see the patient has got a 2 to 1 AV block and the heart rate is only 35. So we could write in the report that the patient was sent with a 2 to 1 AV block, and we could do a more early rapid echo so that the patient does not go into the problem, and we write the heart rate is 35. Number two, remember C. Now here you see the heart rate is about 150 to 120. Now remember, because we always write the heart rate, so and remember in the basic sitting in an echo, you always get a better result when your heart rate is almost below 100 or so. But because it is about 120 here, so it will sort of be some Doppler features or 2D features may be slightly variable. So this is the advantage of having an ECG, which will tell you that what is the heart rate which you have mentioned. Then always, as I said, BP and heart rate. Sequence is always 2D Doppler, 2D echo, then color flow mapping, and then Doppler. Why? This will be easy for you to understand by the end of the talk. So everything, whether it is any study you do, irrespective what is the disease, you always follow this sequence: 2D echo, then color flow mapping, and then Doppler. Now you see these are some of the standard views. You have already been told about them, and I'm sure you will go on remembering at what structures you see in that also. But this is beyond the thing also now at the present. Now, whenever you do, okay, three things are very important. Clinical information, history, clinical examination, ECG, X-ray. Again, as I told you, its value will be told to you as you further progress in the course, because it is very important. You must get a full anatomic information that is by a 2D echo, M mode or 2D echo, which was discussed as a first lecture. By anatomic means, what are the size of the chambers, what are the thickness of the chambers, what are the walls like, and all these other anatomic information is always got by 2D echo, and this is a very important part of any echo study. Then a Doppler, it gives you a complete hemodynamic information. Hemo means blood, dynamic means flow. So the whole body, the pattern of the blood flow is called by a Doppler. A 2D echo, a 2D echo may give you a semi-quantitative information, but a Doppler will give you a more precise information. So don't neglect any of these because they are extremely important. Now, this is a basic hemodynamics which you must have read in third year but completely forgotten by now because you must have not revised it or so. This is a very basic thing. Remember, blue is the unoxygenated blood, red is the oxygenated blood. This slide is very important for you. You should repeatedly go on practicing this slide. The flow from the superior and the inferior vena cava, as you know, comes into the right atrium. Nothing new in this. From the right atrium, it goes to the right ventricle through the tricuspid wall. And so that from the right atrium, when the wall opens, the blood goes into the right ventricle. From the right ventricle, through the pulmonary wall, it goes into the pulmonary artery where it is oxygenated. This oxygenated blood comes into the left atrium and through the mitral wall, it goes to the left ventricle and then through the aortic wall into the aorta. Now, remember, this is known as a right-sided AV wall because it is on the right side. This can be mentioned as the left-sided AV wall. These walls open in diastole and close in systole. Important thing. Every chamber has to fill up, and any chamber fills up only during diastole and empties itself only during systole. Basic remember thing which you many of our candidates don't know this thing till the last day of the course that the chamber fills up in diastole and then ejects in systole. So this tricuspid wall opens in diastole and the pulmonary wall opens. And let us come to first this the left-sided AV wall. Why we call it as the left-sided AV wall? But normally we should say mitral and tricuspid. Left-sided means between the left atrium and the left ventricle is the mitral wall. Again, this atrioventral wall opens in diastole, closes in systole because they have to fill up the ventricle. So any ventricle is filled up in diastole. So these walls open in diastole. Then they have to empty in systole so that the right ventricle, this pulmonary wall, the ventricular arterial wall or the pulmonary or the aortic wall, they open in systole and close in diastole because now they have to push the blood forward. Similarly, the aortic wall, they open in systole and close in diastole. So that this systole and diastole are the basic mechanism for the survival of any patient, and they occur in diastole. Here it occurs in systole. Any doubt, you can go on interrupting and finding out what you want to know. I hope it is so simple that I hope it's clear to you by now. But every day try to read this diagram and get an idea. So that the atrioventricular walls, that is between the atrium and the ventricle, the known as atrioventricular wall, they open in diastole and close in systole. The pulmonary or the aortic wall, known as ventriculoarterial, so say they are between the atrium and the ventricles, and they are between the ventricles and the arteries. A means arteries, they open in systole, close in diastole. They're just opposite to each other. I hope there's no confusion in this and it is clear till now. Now, for example, you see, now forget about which view. This is the parasternal long axis view. You see this is the mitral wall, this is the aortic wall. The mitral valve is closing in systole and the aortic valve is opening in systole. You see it is closes in systole, the mitral valve, it opens. On the other hand, in the diastole, this valve opens, mitral valve, and this valve closes. This closure, this is known as the closure line because that is single line which is known as the closure line, and these are the two valves cusp of the aortic valve, right coronary cusp and the non-coronary cusp. So just to show you that one mitral valve is in systole closed, the aortic valve opens. Opposite is this, when the mitral valve is open in diastole, this valve closes. This is what we have just now told you. Now, two basic important. Now, say for survival, a heart must fill up, a heart must contract. Your blood cannot be static. It will only be static when a person is dead, that it doesn't move after a certain time. Now, take the example of a balloon. Once you fill a balloon with water, it increases in size. That means you have filled the balloon with water and that is increased size, that is diastole because you have filled it. That is diastole. And once you remove the water, it decreases in size and that is systole. So that means a chamber always fills in diastole, and whenever a chamber fills in diastole, it increases in size and that is diastole. So in diastole, any chamber fills. Remember, that is whole thing. And increases in size. In systole, when the ventricle contracts, automatically when the ventricle contracts, it decreases in size. And this is important for survival, a filling and diastole and injection. Remember, two basic things. Diastole is filling of the ventricle, and anything which fills up the ventricle increases in size. A systole is ejection of that blood and decrease in size. For example, let us see here. Again, the same diagram I've shown you. You see, this is systole, this is diastole. So what I tell you, it is fills up. Now you see, in diastole, you see the chamber size increases. You just see. This is left ventricle increases in size. In systole, it decreases in size. Why? Because in diastole, the chamber has filled up. It has filled up, so it increases in size. In systole, it ejects blood, so it decreases in size. So it is right in front of you, diastole and systole. I think I cannot make it more clearer than this also. Now you remember, this my left ventricle is always on the left side. This is left ventricle. This is right ventricle. This is left atrium. This is right atrium. Now see. Now see this chamber, right left ventricle increases in size. Why? Because the mitral valve opens. So now you see the mitral valve is opened. So the chamber fills up and it increases in size. And this is LA. Same thing happens here. The tricuspid valve opens and the ventricle is filled up. Left. So you see in systole, when the valve closes, you see it chamber becomes reduced in size. So these are the atrioventricular valves will open in diastole, close in systole. So when there is a diastole, the valve opens and the chamber size increases, and this decreases, and the same thing here. Now appreciate one thing. When the ventricle is in systole, the atria should be in diastole. Why? Because the atrium has to fill the ventricle in the next diastole. So you see, if you are very careful, you see when the valve closes, the LA size increases. In diastole, it decreases. It increases because now the LA is in diastole because it fills up before it fills there. Same thing here. You see tricuspid valve, when it opens, this becomes small, but when it fills, it becomes larger. Why? When the ventricle is ejecting, the left atrial is filling. Every chamber undergoes diastole and systole. Every chamber increases in size and decreases in size because if the atrium doesn't fill up, how can they fill up the ventricle? Very simple logic, but very easy to understand. One more example. Now you see, this is a three-chamber view. Left ventricle, aorta, LA. You see the mitral valve open, the LV size increases, the LA decreases, you see, and this opens. You see now it is closed, the LA size increases because it is being filled up. The ventricle is getting smaller because it is ejecting blood. In ejection, the chamber falls down. And here you see it is increasing in size. Again, you see, now you see this is diastole. The LA size has decreased because it has filled up the ventricle. So when LA is emptied, it decreases in size. And when the LV is filled up, it increases in size. This is diastole, the wall opens. is open. And here you see it is the again diastole, systole. Systole, you see, it is increases in size. So it is so important that I brought this repeated again. Now see here, in diastole, the LV fills, LA empties into LV. So you see the LV size has increased and LA is decreased because in systole, every chamber decreases in size. What happens in systole? The LA decreases in size because it is ejecting blood, and the LA increases in size because it is filling blood from the pulmonary vein. So see the difference in diastole of LV, the difference of diastole in systole in LV, the effect of diastole on the left atrium, effect of systole on the left atrium. Just to show these slides repeatedly, I am telling you that this time should not you get confused with what is diastole, what is systole. If it would have been a sort of a physical lecture, I would have gone on asking that it is clear or not. But any doubt, please go on interrupting. Just see, every chamber undergoes systole and diastole because the blood has to flow. Every chamber increases in size in distally. When the ventricle is in systole, L is in diastole. Every chamber decreases in size in systole. You see the in LA, it decreases in size and this LB increases. So this is, remember, a systole and diastole filling and emptying is a part of the daily survival of the chambers of the heart. Now, you will hear the term pressure overload and a volume overload. Remember, a pressure overload. I'll just give a simple example. Suppose you are pushing a man of 60 kg. You require certain energy and pressure. Suppose you push a man of 100 kg, you require more pressure, correct? Nothing new in it. Nothing's very confusing in it. When you push a man of 60 kg, you require certain pressure. When you push a man of 100 kg, you require more pressure. So that means pressure overload. That means it is the overload of the pressure. For example, let us say left ventricle. Suppose when there is a hypertension, the LV has to push a blood against an increased pressure. So it has to increase in size. That is known as the pressure overload. Aortic stenosis. There is stenosis between the LV and the aorta. So when the valve is narrowed, the pressure in the left ventricle increases to push the blood. Same thing is the same example in RV. And volume overload when there is too large a blood in the cardiac chamber. Let us give an example of an aortic regurgitation. In an aortic regurgitation, the regurgitation occurs in diastole. Remember, by this time you should know that the aortic wall closes in diastole. So, and mitral wall opens in diastole. So that mitral wall opens in diastole, it pushes the blood into the left ventricle. The aortic wall closes in diastole and in regurgitation, it pushes the blood into LV. So the LV gets an extra blood, which is known as a volume overload, and they usually occur when there is increased size or so. So this will see a gradual over a period of time. Now, very again basic thing which you must have forgotten by now. You see so many ECGs in daily, but you always forget it. What is ECG systole? What is ecosystole and diastole? Now see, you take an ECG from the QRS complex to the T wave in the systole. So and from here it is diastole. Diastole is always bigger than systole because a diastole, it is a very important filling of phenomena. So the P wave is the atrial wave. The QRS complex to the T wave is known as systole, and from the end of the T wave to the QRS wave is known as diastole. Now see here, if you take this from the QRS to the T wave is systole, and from the T wave to the next QRS is diastole. So remember, this is important for you to know because we do a lot of timings based on ECG. That which is diastolic wave, which is systolic wave depends upon the ECG. So again, remember that from the QRS complex to the T wave is the systole, and from the T wave to the next QRS wave is the diastole. And you can always see that the diastole is more than the systole. So this is systole and diastole. Why? There are certain, you take certain structures which are basically mainly based, you can never recognize systole and diastole unless you have got an ECG. Otherwise, you won't know what is systole diastole. Now, what is echo? As a bio, now we told you just now. I hope you have not forgotten the last 10 minutes what I told you. This is the mitral valve. Now, a mitral valve has been told to you. This opens in diastole. You see, this is the diastole. Start from here. It opens in diastole and closes in systole. You see this. QRS complex is systole start and systole ends at the end of the T wave. So even now, if you don't have an ECG, here of course you can know, but certain you will not know which is diastole, which is systole. So this is just to tell you that this is the anterior mitral leaflet, this is a posterior mitral leaflet, and you see this is the diastole. It starts at the end of the T wave, opens, and then closes in systole. So this is how you calculate a systole and the diastole with an ECG. Same thing. Will you should read this. Someday we'll ask you what is E wave, what is F wave, what is A wave, what is C wave. Everything will have a early diastole, late diastole. Early diastole is always known as a rapid filling. When the mitral valve opens in diastole, blood rushes into the left ventricle. So this is the early diastolic wave. Every wave has got a late diastole. You see, late diastole is coming at P wave. You see, this is the P wave. So this is known as an A wave because this A wave is important because it contributes about 30% of the cardiac output. So this is just to tell you, over the course of time, we'll tell you what is E wave, what is F wave, why it occurs, and what is this, and series again the systole. So E is the early opening, A is a atrial wave, and then otherwise this with AC. Now same thing again you see. Now see, this is left ventricle, a mode of the left ventricle. This is LV. You see, this is systole. Systole starts from the QRS complex and goes up to this. In systole, you see the LV becomes narrow inside. This is the ideal slide to tell you that in systole, LV becomes smaller in size. In diastole, it starts from here. You see, after T wave, it increases in size. So you see the difference is this is 4.4 centimeter, this is 1.9 centimeter. If you remember only this slide that you see in diastole, the LV increases in size because it is being filled up from the left atrium and it coincides with the QRS complex. In systole, the LV becomes smaller in size because it ejects the blood. And it ejects the blood, so it becomes smaller. So this is the basic of all these systole and diastole. And I think by this time, please practice today. Please practice and learn today what is systole and diastole so that before the next revision, you should be clear about it. Why I spent more time in it was that I told you that many of the best persons, they even till the last time they do not know why LA dilates in systole and all the vice versa. Now these are just one slide of the physics, nothing a Doppler. If you read a Doppler chapter from any book, you'll not read more than half a page. So it is just a, you must have heard a Hertz. Hertz is what is this? These are the waves. It travels in one wave. In 1 second, there are five waves. 1, 2, 3, 4, 5, that is 5 hertz. So the one hertz is one wave. So if you hear 2.5 million hertz, that means there are 2.5 million cycles in 1 second. So this is only tells you that the sound wave travels in measurable waves and frequency. Now, again, very simple physics. The three things when in a Doppler study, we require three things only: sound source, sound receiver, and they should be relatively moving towards each other. The standard example always given is that suppose you are standing on a railway platform. A train is coming towards you. Once the train is coming towards you, you must have experienced that the sound becomes loud. And when the train passes on the platform, it becomes sound becomes small. So the engine is the sound source, because the sound source is from the engine. Sound receiver is the human ear, because you are human ear also, and they should have a motion of one another. So this is a standard example. Again, you will remember when a train is coming towards you, whistling train, there is a loud sound, and when it passes off, it becomes less. That will be this. So number one, again you see this thing, motion. If you are standing on a railway platform and the train is also standing, whatever whistle the train gives, the same pitch, it doesn't change, because neither the source is moving, neither receiver is moving. Every day you have seen this. You are sitting somewhere, a mosquito comes towards your ear. When the mosquito comes towards your ear, you hear a buzzing sound. And when you do like this, and the mosquito goes away, it becomes lesser sound. So there are three basic requirements in a Doppler: sound source, receiver, and they must be moving towards one another. And if they are not moving, it will be the same thing. Now, coming to our clinical echocardiography, sound source is the transducer. You have already been told about the transducer. Receiver is the million of the red blood cells. Magnitude means the velocity of the RBCs. Remember, for the time being, remember, transducer is source and this. Now, in a train, when the train is moving towards you, you see a loud sound. When the train goes away, it's a lesser sound. But in a echo transducer, any blood which is going towards the transducer is above the baseline. Remember, I'll show you numerous examples. Any blood flow going away from the transducer is a negative shift. So remember two basic things. Any flow of the blood towards the transducer is above the baseline. Any flow which is away from the transducer is below the baseline. Now you see here. And hemodynamics is the backbone, and Doppler is the only technique for the hemodynamics. And it records the velocity and direction, and it is usually indicated either in meters per second or in centimeters per second. So that this will clear to you just now, because Doppler records the velocity. That is known as the hemodynamics. Hemo means blood, dynamic means movement, and then it records the direction, which will show you just now. So this is the Doppler-based technique of a hemodynamics. Now you see, I'm telling you. Now you see. Now this is parasternal long axis view. I said if you are not happy with any imaging, you avoid the structures. But this is the now in a echo. Remember one thing, basic important thing is, in every view the transducer is pointing from above downwards. So you see here, the transducer is pointing, any view scan plane, the transducer is here pointing downwards like this. Whether it is a short axis view, you see transducer is this side pointing downwards. Any view, you see the transducer is above downward. You see the narrow sector. This narrow sector is the sort of a transducer. Now, even you see in a short, in a subcostal view, you see this is right ventricle, left ventricle, RA, LA, and again you can see how the size of the chambers increases in systole and diastole. You see HL. Transducer is again pointing above downward from here. That is the narrow angle. You see, when the wall closes, it's very easily you can see systole and diastole. Systole, diastole, systole, diastole. Oh. Now remember, four chamber view, the transducer is pointing above downwards, like this. So any blood which is going towards the transducer will be shown above the baseline. So you see, this is the LA, this is the mitral wall, and the blood is going towards the transducer. So that means it will be above the baseline, because it is going towards the transducer. The blood is against, it is toward the baseline. Now, for example, you see in a mitral, now here you see the blood is going to, this is the mitral wall, the blood is going toward the transducer, so it is shown above the baseline. So this is the Doppler signal which is showing above the baseline. Again, you see every Doppler, E wave, A wave, E wave, A wave, early diastolic, late diastolic, coming with the T, with the P wave, it is coming. So this is a coming above the baseline. This is the, because it is going toward the transducer. Now, what blood goes inside must come out as come out also. So you see, this is the left atrium. This is a three-chamber view, LA, LV, and the aorta. So the blood cannot, the blood which goes inside has to come out. It cannot remain inside. So the blood which is going into the LV is coming out toward the aorta, and this is going away from the transducer, which should be below the baseline. So here you see blood going toward the transducer is shown as a positive, and the blood going away from the aorta, away from the is shown as a below, and you see here that is below. So you see, this is nothing special. Only remember, in every view, the transducer is pointing from above downwards, and any flow visit toward the transducer is shown as above the baseline, and any view, any flow which is against the transducer is shown as a negative. So this is known as the negative Doppler shift, and this is known as a positive Doppler shift. Positive means it is above the baseline, so it is a positive Doppler shift toward the transducer, and this is a negative Doppler shift because it is going away from the transducer. Away from the transducer, negative, going towards is positive. Now see, now don't worry what you see here. Now the advantage of this ECG is we know which is diastole, which is systole. Now, see, the horizontal line gives you the timing. This is known as the zero line. Zero line gives you the timing. They give you the velocity. Say this is it is 1 meter, 2 meter, 4 meter, 6 meters. They give you the velocity. So they tell you which is the velocity of the diastolic flow or this, that tells you this. And this will tell you the shift. This is positive shift, this is negative shift. Now this will be too much for you, but remember, this is the aortic wall. Now this is the shift which is in systole. So that means the blood is going away from the transducer. So that means it is the aortic flow going away. Now here you see blood is going towards the transducer in diastole. Diastole is from the T wave. So in aortic wall, any flow which is going toward the diastole, usually the aortic regurgitation. So because now this is, I told you it may be difficult for you, but main thing I want to tell you, zero line tells you the time. This above and below tells you the positive Doppler shift, negative Doppler shift, and it tells you the velocity. You can measure the velocity here also. You can measure the velocity here also. And you see, this is how, why the ECG is done. Tomorrow you may say that no, it is not that, it is systole. No paper or anything will be entertained without an ECG. Now remember one thing, you in Doppler, you get the best possible results when you are parallel to the blood flow. In a 2D echo, you get the best possible results when you are perpendicular to the flow. So certain amount of deviation is permitted, but not too much. And the whole Doppler result depends upon this. So you have to be as parallel to the blood flow as possible. Why I'll tell you just now. Now there are three Doppler modalities. Remember, it is not difficult. Now remember what I have to tell you is why the Doppler results depend upon this and why you have to be as parallel to the flow. Now you see, one is a pulsed wave, one is a continuous wave, and one is a color flow mapping. For you, remember three things also. Now, these are the three Doppler modalities. Just forget about it. This is known as a sample volume. This is a pulsed wave. Wherever it is situated, you can only record from that place. So that means, and it only records a low velocity flow. Now, you may feel it difficult at something. In a continuous wave, it measures high velocity flow and there is no sample volume. So suppose I want to measure a mitral flow. I will bring a sample volume to the mitral. Suppose I want to measure the aortic flow, I'll bring a sample volume here. Now you see it is again automatically come. So it is again, you see, any doubt, it is again, because I don't tell you what is one crystal and two crystals also, that you can also read also. But remember, it measures all high velocity flows. It measures only a low velocity flow. Hence, it is known as the range resolution, because you can only go up to a certain range. Now you see, it is a low velocity flow. It is a high velocity flow. It has got a sample volume. This is sample volume from where you can record a precise velocity from a particular site. It has got no sample volume, so it can record from all over wherever this Doppler volume is there. So you see, and something known as aliasing, because aliasing is something now in every Doppler you have seen. The signal is whole Doppler signal is seen very nicely. Now here you see whole Doppler is seen very nicely, and the whole Doppler should be available into the scan plane. Now if you this when every pulse sample volume has got what is known as the Nyquist limit. Nyquist limit is the maximum measurable velocity you can see from that sample volume. To you. Now you see this is like a cut here on the mitral wall, and we are only recording the mitral wall. So you see that it is above the baseline, so nothing below the baseline. Now you see the aortic wall below the baseline, and you see again it only tells the velocity. Now here you see, I will come to it later on. Now you see what is happening here. This is mitral wall. The mitral wall opens in diastole. This is systole. The ECG is hidden below. And you see above and below. You see above and this is below. So it will be, I have written to be demonstrated, where it will be easily understood by you. Now here we know that the Doppler starts from here. We can measure from here. Here you don't know where it ends, where it goes. So this is a high velocity flow. MRZ is always a high velocity flow. And we have purposely put a pulse Doppler, and we got this. Now, once we put a CW Doppler, you see the L of this disappears. Because now it is all CW Doppler records a high velocity flow. So thus it will be easy for you to understand during a session that we demonstrated. But the main thing is to show the aliasing occurs if you use a pulse Doppler at a high velocity flow, and if you a CW with all high velocity flows are here. Now, aliasing can be physiological and pathological. Physiological means that suppose you have recorded a velocity, ask the patient to run about 10 for 20, 30 steps, his blood flow will increase. So that is physiological aliasing. When only all, for example, patient of severe anemia, third also goes a high velocity flow. Pathological is because of certain diseases. Again, for the time, shifting of baseline and when to do a CW Doppler written there. Just to give you an example. Now see, this is the mitral wall. This is we have put it here. This is above the baseline. This is below the baseline. The zero line. The zero line shows 1 meter per second. If you put the baseline above, the velocity will increase down below because it is in the opposite direction. Now see. You see, we have taken it above. The velocity here becomes 1.2, here becomes 0.5, and this opposite thing occurs. So again, I'll tell you that don't get disheartened. This will be shown to you during demonstration, and then you'll be very clear about it. Now remember, for you, a pulse Doppler we use across only a normal walls and a blood vessels. These things you'll remember later on. You'll tell later on also. So when you are studying a normal structure, you see for a pulse Doppler. All disease flow are high velocity flows, and we use a continuous wave Doppler because a high velocity flow is only a disease flow. a stenotic valve, regurgitant valve, prosthetic valve, and shunt flow, all these things. So remember, a pulse we use for a low velocity flow, and this we use a high velocity flow. Now, the principle is that suppose you have put in a pulse Doppler at a particular structure, you get an aliasing. That means it is a slightly higher velocity flow. Switch on to continuous wave Doppler. And then this aliasing will dissipate. Then whether you know it is a physiological aliasing or it is a pathological aliasing. Remember, all disease flows, remember basic thing. For you, the teaching has been, but we don't follow that teaching ourselves. The teaching is start with a pulse Doppler. If you find an aliasing, go to a CW Doppler. But what we do, once we know that is a patient of a any valvular is something, we directly go to the CW because you know it will be high velocity flow. Now, why I say that you have to be as parallel to the flow, according to the equation, all velocities are converted to gradients. In a rough chamber, the gradients means a difference of pressure between the two chambers. A blood always flows from a high pressure to a low pressure chamber. Now, suppose you take a case of mitral stenosis. The mitral valve is narrow, so the pressure in the left atrium will be more. In aortic stenosis, because of a narrow valve, the pressure in the left ventricle will be the more. So this difference of pressure between the two chambers is known as the gradient. And according to one of the formulas, accepted formula is 4 into velocity square give you a gradient. Suppose you have recorded a 4 meters per second at the velocity, 4 into 4, 60 into 4 becomes 64 is the gradient. So remember, a gradient is the difference of pressure between the two chambers. Number two, blood always flows from a high pressure to a low pressure chamber. Now, suppose you have taken the velocity as result at 3 meters, it becomes 36. So that means your aim should be always to record a very high velocity flow. That is there, you should be as parallel to the flow as possible. Because if you are not parallel, and then we should record a lesser velocity gradient will be reduced. Now, for example, here machine automatically collected. Now here the velocity is 5.4 meters per second. It automatically gives the gradient of 122. We have not done anything. Our role is to get a best possible velocity. The machine already gives us the value. Again, you see, aortic wall below the baseline, systole, the velocity is recorded 4.72. Machine automatically gives us the 89. And this is again, it is a mean or so. So that our duty is to get a best possible Doppler signal and the machine automatically converts it. If your velocities are wrong, then you cannot, then all your results will be wrong. That is why we'll tell you later on when you come for a particular valve, we always take multiple views to say that which views gives us a maximum possible. So only thing to remember is that try to get a maximum velocity, a low velocity by pulse Doppler, high velocity by a CW. Now see, now you see, say this is, you can see a sample volume which is cut. In that case, there is no sample volume. It is just a straight line. There is no cut in between. So that is straight is recording blood from all these areas also. Again, you see, this is a mitral regurgitation because it is in systole below the baseline, and this is a diastole above the baseline. We have recorded the velocity as 5.71 meter per second. The machine automatically gives us a gradient of 130. So your job is to get the best possible velocity. I hope this is clear to you. Just few example, but remember, a stage will come that it will automatically you will start knowing about it. Now, there are one important is now one is the P gradient that you take maximum velocity. For example, this is the P gradient. You have taken the P gradient, and that is the this is the peak gradient, and here give you the velocity, the millimeters. So, and the mean is when the average of multiple gradients. When you take an average of multiple, you always get a better result. When you, for your marriage, if you see only one lady, that is a peak gradient. If you see five ladies, and then decide that's a mean gradient. So that means you have got a choice about this. So when you average it, you get the best results. So a velocity time integral, you'll get a repeatedly you will get this word also, and we tell you it is how much centimeter the blood travels in one stroke. I'll give you an example just now. Now you see, this is if I tell you, I will say this is a pulse Doppler because we have put a, this you can see the cut. Number two, the LV this side, so this is the mitral wall, and because the blood is going toward the transducer, it is a mitral. Once you trace a mitral Doppler, you get everything, peak, mean, and VTI. VTI means that the blood traveled 23 centimeters in one stroke. So by recording, remember, by recording a peak, I'll again explain you, don't get confused. By recording a peak, you get a peak velocity or the peak gradient. This is peak. But once you trace it, you get peak, mean, and VTI. So you will now here you see we have not got any here we have not got any mean, we have not got a VTI. But here you see the aortic wall, we have got a peak, mean, and the VTI. So when you trace the other, suppose you're asked a question, how do you calculate a VTI? Then you say by tracing the Doppler envelope. Or how do you calculate a peak and mean gradient? That is by tracing a Doppler. So again you see what I showed you just now. This is the aortic wall. It is in systole, away from the transducer, CW Doppler, trace it, you get peak, mean, and AV VTI. VTI is, will be a very, very important thing for you in future. Its importance will be shown to you with L. So this is a how much distance it travels in one stroke is the VTI. If suppose today it travels 25 centimeters, that means heart is contracting well. Tomorrow come down to 20, that means heart function has decreased. So this will be later on told to you. Now, so we have finished briefly the basics of a clinical and this Doppler now. Now we come to just the last minute of the color flow mapping. It is the major breakthrough. We can see the blood. In a plain Doppler, we could not see the blood, but here you can see the blood, and then you can put your Doppler according to the direction of the flow. So it can be faster detection of flow. So it's a very major breakthrough it came that once you see a blood flow, you can push your Doppler parallel to it. By a universal convention, flow toward the transducer is shown as a red, flow away from the transducer is shown as the blue. Same thing, a positive and a negative Doppler shift. Now, for the example, you see, this is LV, LA, aorta. Blood between the transducer is always pointing above downwards. The blood from the LA will be going towards the transducer, will be shown as a red color, and the blood which is going away from the transducer in the aorta will be shown as a blue color. Now you see here, you see, this is the blood going from the toward the transducer as a red color, and this from the blue flow which is going away from the transducer is known as a blue color. This color aliasing will be told to you because this is also based on the principle of a Doppler ultrasound, the pulse. So you can very easily see blood toward the trans. So you have to only remember one thing. Forget other thing. The transducer is always pointing from above downwards in every view. Flow going toward the transducer is of a red color with a positive Doppler shift. Flow going away from the transducer is a negative one. Again, you see. Now I put a still image. Now this is LA and LV. This is some of you will be keeping LV on this side. So you see blood going towards the transducer shown as a red color. You see this is LA, LV. This transducer pointing above downward, and you see the blood going into the aortic wall away from the transducer shown as a blue color. Very simple. I think I can't make it more simpler. It is such a fantastic technique. It can only, this was a prosthetic wall. only two smallest jet it could detect. Now you see, now they are going towards the transducer. So the jet is going from the aorta. That means it is of a small aortic regurgitation. Forget about it. Now, remember one thing, comparison of CFM and Doppler. All red flows towards the transducer. Automatically, all Doppler flows will be above the baseline. Doppler, blood going toward the transducer, above the baseline, blood going toward the transducer, above the baseline. All blue flows will have a Doppler below the baseline because they are going away from the transducer. Towards and away. Now you see, this is the pulmonary wall. Now, because the blood is going from this side, away from the transducer, it is of a blue color. This is the RA, RV, pulmonary wall, pulmonary artery. So blood is going out of the right ventricle. It is of a blue color, and you take a Doppler. It is of a blue color here. It is negative. So basic principle, जो I don't know how to indicate it. Any flow toward the transducer is of a red color, and all red colors will have a positive Doppler signal because the blood is going toward the transducer. Negative is this side. Again, you see, this is still even, this is a mitral, this is a left ventricle, LA. The wall, the blood is going into this MR, that away, that is any blood going there is below the baseline, and this is shown below the baseline, any blue flow below the baseline. Now you see here, this is the aorta, this is the flow going to transfer, which is of a red color. So this is a red color aortic regurgitation, and this is a blue flow will go in this. So just think it is a very basic thing which you will automatically remember very shortly or so. Again, you see, again you short the exercise, this is RA, this is tricuspid wall. From the RA, the blood is going toward the tricuspid wall, toward the transducer, above the baseline. And when you put a pulse Doppler, tricuspid wall above the baseline. So I think these are some of the very important basic things also. So and remember turbulent flow, when there is a disease, what we have shown you till now is a normal flow. A disease flow is known as a turbulent flow. And they are of a multiple colors. For example, here I showed you, this is the normal flow. Again, this is the normal flow, you see. A normal red, normal blue, normal red, normal blue. But here you see again a tricuspid wall and you see a normal red with uniform color. But here you see, this is a turbulent flow. This is a case of a mitral stenosis. You see a mixture of colors. Why this is known as a turbulent flow, a mosaic like? Because in our time there used to be mosaic floors, but now they have been replaced by marble tiles or so. So you see the significance is that suppose you hear a systolic murmur in a patient. Now systolic murmur can be many causes, can be aortic stenosis, can be pulmonary stenosis, can be VSD, can be MR. So the thing is that suppose you are suspecting VSD, put a color flow mapping, no turbulence out. Because any disease flow is a turbulent flow. No, but if you are now here you see the systolic murmur. Now here you see huge severe MR. This is the LA, this is the LV, the turbulent flow. So here immediately we know that this patient has mitral stenosis with regurgitation. So don't worry, ये सब आपको बाद में पता जाएगा. Again you see the aortic wall. This is the LA, LV. This is the aorta, three-chamber view. Blood going toward the transducer, a red color and blue. Again you will see the same thing, turbulent flow. Again you see LV, LA, RV. You can see two jets, blue jets, MR and TR. We can go on showing you many examples just to show you that they are above and all the Doppler signals will be below. Now see, these are the TR and this is MR. So the now last slide, the basic difference between 2D and Doppler is In 2D echo, you see the tissues. In Doppler, you see the blood. As the Doppler indicates, you see the blood flow and the velocities. It gives you a structural information. 2D structural means how thick are the walls, how thick are the septum, what is the size of the walls, all these things. And a hemodynamic information is obtained by a Doppler. Here you have a best results you see when you are perpendicular. That is why the parasternal long axis view is best seen because you are perpendicular. Here you see it with a parallel, same thing. And quantitation semi-accurate. The main thing is that here you are seeing the tissues, here you are seeing the blood, here you are getting the anatomy, here you are getting the hemodynamics. Here alignment is completely parallel is always best. A parallel is here that is perpendicular and parallel. You get a accurate quantitative information. For example, here I say suppose you get to see a patient of aortic stenosis. And the more valve is thickened, the more the LVH because the pressure load, the more is the severity of the aortic stenosis. But accurately you can determine by Doppler. So tips: use pulse Doppler in situation of normal flows. If aliasing occurs, revert to CW flow. Use CW in all disease states where high velocity flow is expected. Place sample volume tip of the leaflet in the pulse Doppler. Tip of the leaflet. Now, remember two basic dictums. Now, be as parallel to the flow as possible. How? Just remember in which views you are seeing this ball. That you will get an experience when you have reread your lecture number 1. Am I parallel to the flow? That is the two basic dictums. In which scan plane you are seeing this structure and parallel to the flow. I'll give you an example. Pulse Doppler, sample volume placement at the tip of the leaflets. Use multiple imaging band to get the maximum velocity. Nothing short of a maximum velocity to avoid the pitfalls. Now this will be shown to you, demonstrated how to get a good CFM, how to get a good Doppler. Again, there is no point in telling you theoretically, but let's see. Again, you see, now this is the parasternal long axis view. Transducer is pointed above downwards. This is the mitral wall, this is aortic wall. Now we are perpendicular to the transducer. So there is no, you cannot do any Doppler study of the mitral and the aortic wall because you are not parallel, you are perpendicular. Same patient, when you are going to the apical view, you see you are directly parallel to the flow because it is going toward the transducer. So you can get it. So you see again, you see where you put the pulmonary artery. Now this was again mitral and aortic wall. There are many views for aortic wall which will be told to you. And for a pulmonary wall, best is this is short axis view, but you can see from other views also. Now, this will not be discussed. This is for the tricuspid. There are various views also. You can see from the various views, you can see the tricuspid wall. So we are not going to discuss this thing also. So any clarification now? Please read it. If you read it after 5 days, you will forget. Read it today. See what certain amount of doubts, but I cannot think that I can make it more clearer to you by giving so many examples as to what is the basic of the Doppler. So, so if that if you so your clarifications will come only when you have read the topic. If anybody has got any doubt, you can clear it now. Otherwise, there'll be a demonstration of the first two lectures. You can discuss it there also, get a clarification. So I hope some of you have understood what is this sort of a very scary subject of Doppler is not there. Surprisingly, in your what I have seen that in your hands-on training, they learn better the Doppler rather than the anatomical, rather the M mode or so and calculations or so. So please read it. Any doubt, just let us know.
Good evening, sir.
Anji.
Sir, few people ask for the questions. One is Dr. Nayak from Srinagar. Dr. Nayak,
हाँ.
ask your question, please.
Good evening, sir.
Good evening, bhai.
Thank you, sir, for an excellent talk. I want clarification for just an anterior mitral leaflet and posterior mitral leaflet you mentioned on ECG. How can we trace these closures?
E.
AML and PML on ECG.
हाँ.
ECG
No,
tracing.
you can't see an individual leaflet. You have to see the whole mitral leaflet. In you individual, you see only you see in this in the echo, but here you don't see. You only see the now you see. You see, now this anterior and posterior, you see only in echo. Here you can only see that in diastole the mitral valve open and systole closed. That's all. But the anterior leaflet and posterior leaflet, which move in opposite direction, can only seen by an echo.
Okay.
ECG is only for a timing, systole, diastole. That's all. But the anterior posterior leaflet is only seen in a sort of a echo in the echo only. Huh?
Okay, sir. Sir, what is this F wave?
ECG is mainly it is timing. Now, suppose you don't have an ECG, then this may tell you this is mitral valve because you see how it opens and closes. But normally, the ECG only tells you rate, rhythm, and the timing of the cardiac cycle, systole, diastole. That's all.
Okay, sir. Sir, one more.
Yeah.
Yes, sir. One more question, sir. How can we on aliasing? How can we differentiate physiological aliasing from pathological aliasing?
Physiological, anywhere physiological means that it is because of some physiological cause, such as exercise, anemia, thyrotoxico, they are high outflow rate. A peak Doppler, a peak Doppler is depends upon the flow. Then if the flow is increased, the velocity will increase. So suppose this, so what happened that there is a physiological ones mean that there will be no turbulence. It will only be an aliasing, no turbulence also. And to confirm it, put a CW Doppler. Suppose it is a low velocity flow. Suppose the mitral velocity flow is about 1.20. Suppose you go to 1.90, it will show some sort of aliasing. But once you have a doubt between physiological and pathological, try to take a CW Doppler. But physiological is non-pathological. Only increase in the blood flow. That is why I said in many patients, the peak, for example, in mitral stenosis, so we don't give importance to the peak gradient so much as compared to mean. Because peak can vary on a day-to-day basis. If today you have taken a recording in the morning, in the evening you develop some sort of severe anemia, your velocity will increase. If you are stressed, if you are exercise, your velocity will increase. So that is the physiological one, is the non-pathological, and they are usually of a low velocity. They are not that high velocity as a pathological one, which go into 4, 5, 6 meters or so. So most of that you will remember when you will teach, when we show you.
Thank you, sir.
Dr. Shantanu, ask your question, please.
Good evening, sir. Thanks for the wonderful lecture. So, firstly, in the same slide which is
Right.
currently in front of us, if I may ask, we know now we know that we've revised that in diastole the mitral valve opens and the ventricles fill up. However, in this particular M mode image, sir, can you please trace as to where exactly the valves are opening and closing? Just to have a slide out just to reconfirm that.
Now,
Yeah.
now this is anterior, this is posterior. In any echo, this is anterior,
Sir,
this is
sir,
posterior.
sir.
What M mode picks up is what you have seen in the echo. It M mode 2D. This is M mode. Now in a 2D echo, this is RV. This is
Sir.
RV. This is interventricular septum. This is interventricular septum.
Sir.
This is This is mitral valve, this is mitral valve. So this is anterior, this is posterior. That is
Sir,
why we say the pericardium is the most posterior structure.
sir.
So this moves anteriorly and this moves posteriorly. So this
Okay.
is you see this is the anterior leaflet is moves anterior, that is posterior.
Okay.
That you know because today is only this question you should have asked on the first lecture.
Sir, and secondly, I have one more question. While evaluating the Doppler studies at the levels of different walls, the PW and CW, you told that CW is mostly for turbulent flows. So while examining, let's say for mitral valve, do we do PW for each of the walls, or is it specific that
So what
for
I told
mitral?
you,
Yeah. If in
say you
physiological
see,
conditions, sir, not in pathological. In normal physiological estimation, the
as I
first step.
told you, as I told you, you according normal walls and vessels, you put a pulse Doppler at the tip of the leaflet, and you can use this also. If you want to increase the velocity above, put the baseline down. So you can use a pulse Doppler mainly in these cases also because it is a normal flow. If the suppose there is a mitral stenosis, then it is a disease flow. All disease flow use a CW Doppler. So that is very simple, basic thing. All
Okay.
disease flow, high velocity flow.
Okay. So firstly, at the levels of all walls, we'll use only PW only to start with. The first step.
Yeah.
Okay, sir.
Depending velocity, I put at the
Okay,
tip
sir.
of the leaflet. Huh?
Okay, sir. Okay, sir. Okay,
And
sir.
where is a doubt, put a CW.
Okay. Okay. Got it, sir.
Dr. Lovedeep, ask your question.
Yes, good evening, sir. Sir,
Good evening.
kindly repeat that aliasing slide, sir. Can you please repeat it, sir? What is
मैंने
aliasing?
आपको I have told you I have written to be demonstrated. You see here
Okay,
you
sir.
know. Now this is the mitral wall. This is diastole. This is
Yes.
systole. I have purposely put a pulse Doppler. Just put a pulse Doppler to show you see above and below the baseline. You know
Yes.
here you can measure from here the mitral wall. Here you don't know from here to measure. It is going above and below the baseline. So
Yes.
here you see once you put a CW, it aliasing disappears and everything comes below the baseline because it is a negative Doppler shift also. So by CW you can use it also, but I think it will be demonstrated that you can understand it better. We can in our hands-on we can create a a sort of aliasing. Suppose we are taking an aortic valve, we reduce this velocity. This is known as the velocity scale. Scale above below you reduce the velocities. अभी तो आपको ये बताना कि what all you see in a Doppler. Then it will get you can get an idea of the aliasing very well. Don't worry.
Okay. Thank you, sir. Thank you.
Sir, no more questions, so we can stop here.
We can stop and then let them read, and then I think there is a demonstration of both the talks on some day. So they should become prepared. Don't leave it for 5-6 days or so. In last batch, many students came without reading the first two lectures, and they were in a terrible state right till the last day of the FD. So I'm telling you today that once you come for a hands-on, read the first two chapters again and some basic things. I think this will be told to you. Don't worry now. Relax. Okay then. Any doubt, you have got our email address, you have got our telephone number. You are most welcome to recap anytime. Okay.
Okay, sir. Thank you. Thank you very much. I hope they really learned about your Dopplers of echocardiography. And we are going to have next batch where we are going to next class where we are going to show live demonstrations of MO 2D measurements, then Doppler flow. So get ready with your questions so that we'll be interactive and we'll possibly start at 6 o'clock in the day on that day. so that you have enough time, about 2.5 hours, to answer your queries. With this few words, let me pay thanks to Dr. Parashar sir and each one and every one of you to remain attentive in this program. And we have about 40 delegates right now present over here. So let me just quickly take your attendance.